Hi everyone, I'm super happy to be here this evening and to co-host this with John and also Claire Woodley. So what we're going to talk about this evening is the European Hematology Association. It was actually the 30th meeting in Milan recently. It was as hot in Milan as it's been in the UK. There were lots of attendees at this conference, and just put some facts and figures on this slide to give you a flavour. If we go to the next slide, you'll see the size of this Congress is sort of matched not only by in attendees, but also in terms of how many sessions there are, how much information is exchanged. But this was a really, really important Congress for MPN. So we had, and we're going to be bringing you most of this information this evening. So we had late breaking results in ET with the first data from the CALR antibody studies, so expect to hear about that. We had debates about whether clone size matters, so I see some of you have already pre-submitted questions on that. And we also had a plenary session regarding interferon, and I can see some questions have been submitted with regard to that. So I want to really thank my colleagues who have prepared lectures. Some of them are videos, some of them are joining live, and we'll have a Q&A session. Do put your questions in the chat and we'll try to answer them. If you've already submitted it, we've got them and we're looking at them. But I really hope you enjoy the webinar. I hope you find it useful, and I hope it brings you lots of hope and excitement with regard to new data in the field. Without any further ado, we will now be playing a couple of videos from some colleagues. One is Patrick Harrington and the other is Andrea Domenico. Now, these are videos that were actually pre-recorded on work that's been done, firstly with the app, and they were done for a medical audience. So excuse the appearance of the videos. So let's hear from Patrick.
Hi, I'm Patrick Harrington, consultant haematologist at Guy's and St Thomas's, and I'm going to present my abstract, My MPN Voice, a novel smartphone app for monitoring patient-reported outcomes and biometric data in patients with myeloproliferative neoplasms. So we know that MPN patients frequently have a high symptom burden, and they're also at increased cardiovascular thrombotic risk, making healthy lifestyle practice particularly important in this patient group. Because of this, we've created a patient app called My MPN Voice with an associated approved research study to track patient-reported outcomes and biometric data in patients with MPN. This study allows patients to be recruited from across the UK without attendance at any specific hospital site. Patients are given a digital patient information sheet and provide informed consent virtually as well, after which, if they're eligible, they are sent an FDA-approved wearable device, a Withing smartwatch, to track their biometric data, which feeds directly into the app, as you can see in the image displayed here. We also have access to patient electronic health record data via a subject access request to allow us to really get into the granularity of patients' medical histories. So the app was launched in April 2024, and so far we have over 400 patients using the app across the UK. These patients have a median age of 61 years with a range of 24 to 85, and they are 64% of them are female. Patients have a median follow-up currently of 226 days, and so far we've collected 2.7 million data points over 70 plus distinct variables. And this image on the right here shows how the app looks on patients' smartphones. You can see the MPN 10 score listed here, which lists the 10 commonest symptoms observed in patients with myeloproliferative neoplasms, and users are able to score this on a 0 to 10 scale to provide a total score out of 100. And this can be tracked over time to assess for any signs of disease progression or increase in symptom burden, as well as the impact of any therapeutic interventions. So if we look briefly at some of the results, what we have on the left is the MPN 10 total symptom score. I'm just going to drill down on a couple of interesting bits of data. Firstly, we see, and this is recognized across MPN patients, that fatigue is the commonest symptom across all MPN subtypes. So we can see the different MPN subtypes shown by different shades of blue, essential thrombocythemia in the dark blue, myelofibrosis in the light blue, and polycythemia vera in the intermediate shade. And fatigue is the commonest symptom across each of these subtypes. If we then look at some of the symptoms that are overrepresented amongst specific disease subtypes, we can see here that itching, pruritus is particularly common in patients with polycythemia vera, whereas myelofibrosis patients have a significantly increased frequency of night sweats. And these findings are commonly observed in myeloproliferative neoplasm patients, and it was good to be able to verify this with this real-world data set. If we then move on to the quality of life score, and what we have here is the health state score, which combines data from the EQ5D5L. And what we can see here is that patients with a myelofibrosis diagnosis had a significantly lower quality of life score than patients with polycythemia vera and essential thrombocythemia. And similarly, if we look at the biometric data, again, patients with myelofibrosis had a lower step count than the other MPN subtypes. If we then look at some of the specific data amongst different disease groups and look at the impact of treatment, what we show here in the interest of time is just the data for essential thrombocythemia. And we can see that patients taking the cytoreductive therapy hydroxycarbamide had both the highest MPN-10 total symptom score, shown here, as well as the lowest EQ5D5L quality of life score. And this spider diagram here shows that the symptoms observed skew towards fatigue and inactivity, particularly in those patients receiving hydroxycarbamide as well as interferon. Those patients just having active surveillance had the highest quality of life score and the lowest MPN-10 total symptom score. And finally, on this slide, we show data for a correlation matrix looking at each of the individual MPN symptoms that we collect via the MPN-10 TSS, as well as each of the individual biometric data points. And we can see various positive and negative correlations between these metrics. And if we drill down again on a specific example, what we see here in this highlighted line is the fatigue score, which we saw was the commonest symptom observed. And we can see a negative correlation between various activity metrics such as distance traveled, step count, intense activity performed, showing the impact that this fatigue is having on patients' activity levels. Similarly, the image here shows the impact that fatigue has on quality of life. So here we have correlation between fatigue score and quality of life metrics, both the EQ5D5L and the health state score. And we see that these patients with the highest fatigue score had the lowest quality of life score. So again, nicely bringing these different forms of data together. So that's the data that we have to display, and I would encourage everyone to continue to monitor for this study as we continue to expand our patient population and continue to get valuable insights using this novel approach.
So a huge thank you to Patrick, who unfortunately can't be here. And this just shows, I think, how important the app is. This had massive interest at the conference, and hopefully we'll be able to do a bespoke webinar for you soon on the app. Next, we have Andrea Domenico, and Andrea did some work looking at cardiovascular risk scores, and indeed a very common risk score that GPs use in the UK called QRISK-3. And he looked at how well this predicted events for MPN patients. So let's hear what Andrea has to say.
Hi everyone, I'm Andrea Domenico, and today I will discuss our poster recently presented at EHA regarding the role of the QRISK score in identifying essential thrombocythemia and polycythemia vera patients who can benefit from early cytoreductive treatment. As we know, thrombosis risk adapted management in PV and ET considers age over 60 years old and previous thrombotic events as a significant risk factors. Additional factors like hypertension, high hematocrit, and JAK2 allele burden are also influential, but type no, not adequately assessed. The aim of our study was to assess and quantify the cardiovascular risk factors to identify patients who might be overlooked by current risk stratification, but would benefit from an earlier cytoreductive treatment based on the use of the QRISK model. That is a model previously validated in a larger cohort, a big cohort in the United Kingdom. Through ROC analysis in a cohort of 490 ET patients and 447 PV, a threshold for a QRISK-free of equal or greater than 7.5% indicated an high-risk patients. Our analysis showed this score can effectively differentiate patients into high and low risk categories. Standard low-risk patients had a Q-risk lower than high-risk group. Moreover, in essential thrombocythemia, approximately 24% of ET patients fell into the high-risk category based on the Q-risk, and it is associated with about 25% in the cohort of PV patients. Moreover, we found that cytoreductive treatment significantly reduced the thrombosis in high-risk ET patients based on the Q-risk. Specifically, about 80% of treated patients with cytoreductive treatment remained thrombosis-free compared to only 64% of untreated patients, with a statistically significant improvement with a P of 0.02. In the high-risk cohort for high-risk PV patients, the cytoreductive treatment with hydroxycarbamide, ruxolitinib, or other treatment demonstrated an even more notable predictive effect. About 87% of PV patients remained thrombosis-free, higher than the 57% of the untreated group, highlighting a substantial protective benefit with a P of 0.003. As we can see in this slide, that splits ET and PV patients according to Q-risk and standard model. The Q-risk score effectively significantly outperformed the standard risk stratification methods. Its threshold of 7.5% effectively predicted thrombotic events during the follow-up, splitting patients into clearly distinct risk groups when it was evaluated in combination with the standard model, with a significant of P less than 0.001. So we can see in this slide the groups with Q-risk higher than 7.5% as an higher incidence of thrombotic events compared to patients with Q-risk lower than 7.5% in both cohorts. In conclusion, we recommended the use of Q-risk alongside standard scores for these MPN patients. It reliably predicts thrombotic risk, enabling so a better informed therapeutic decision and then improving the patient's outcomes. And thanks for your attention.
Okay, so essentially, Q-risk 3 is a very simple score that you can calculate, and your GP actually, when you're 50, should be calling you, if you're a UK listener, in for a score. And usually your GP would send you on for review of your cholesterol or your blood pressure, etc., if your Q-risk score is above 10%. But what Andrea's work is suggesting is maybe 7.5% may be useful for MPN patients. So certainly in the UK, as we'll discuss in the panel, we've started to look at whether this might be something that is useful or could be used maybe in addition to other standard risk classifications. And just while we're waiting for John Lambert or Beth Saylor, who are our next speakers, to join, maybe I'll ask Claire to comment on that. Claire Woodley, if you don't mind. I can see you're in the room.
Sorry, could you just repeat?
Yes. How could a patient calculate their Q-risk 3 score?
Okay, so if you actually go online, there's a website where you can go on if you put into like a search engine Q-risk 3, and it will come up, and it asks for information about kind of a little bit of background to yourself, so kind of your height, your weight, where you currently live, your postcode, just so that it can equate for regional differences. And then it asks you some medical history questions, so about if you have certain conditions. You need to know your height. Ideally, you would need to know your height and your weight, a blood pressure, and your cholesterol levels. And once you've put in all of that information, it will then give you your score of your 10-year risk score for a cardiac event, and will compare you to kind of somebody of a matched age.
Yeah, exactly right. And so what Andrea found in his work was that actually, especially if you're what we would regard otherwise as a low risk patient, so for example, if you're under 60 and or you haven't had a blood clot, then if your Q risk score is high, then that definitely needs to have some intervention. So this is something that we'll be looking at. Now, Beth, I can see that you're in. I can't see if John Lambert's in yet, but I wondered, Beth, if you would be ready maybe to do your presentation.
Yeah, great. I can do it now. Let me
Perfect.
try and share my screen. 1 second. Can you see this?
Yes, and we're super excited to hear it. Fantastic.
Great, yeah. So thank you, everyone. I'm sorry I missed the talk so far, but really excited to be here. So I'm going to give you a short update, just 10 minutes, on some new therapies coming through the pipeline that are targeting mutant calreticulin. Let me just turn that off. Great. So these are immunotherapies. What that means is that they're agents or drugs that are given to patients, and they engage your body's own immune system to try and attack your MPN cells. There's a lot of different types of immunotherapy agents that we use. Some of them are actually used routinely in clinical practice already, the non-specific types of immunotherapies, such as steroids, interferon. These are all actually immunotherapies. But these new agents we're talking about are much more targeted. These can include anti-cancer vaccines and antibody therapies, where we give people basically artificial antibodies that are engineered to attack specifically the MPN cells. Some of these antibodies, and there are also other types of therapies, then engage your body's own T cells to then attack the MPN cells, and I'll walk you through those now. So why is this exciting, and why can we use these in patients who have an MPN driven by calreticulin? Well, that was all, the mutation in calreticulin was discovered basically just over 10 years ago. And very interestingly, what it does is it sits on the surface of key cells that drive an MPN. So in this image here, you're looking at a cell. The red blob here, that's actually mutant calreticulin, and you can see it's traveled up to sit on the surface of the cell, attached to this cell surface receptor here. So it sits there on the outside of the cell, and actually all the known types of mutations in calreticulin create the same new bit shown in here at the end of the protein. This is a prediction of what the protein looks like, and you see this red bit at the end. So that's common to all the different types of mutations in CALR that appear, and that means that we're able to then design therapies that selectively target the mutation in calreticulin. This is quite different from mutations in JAK2, say, because the JAK2 mutations and MPL mutations actually too are both hidden inside the cell, so they're not visible for the immune system to attack. So this means that we can now design therapies that are highly specific or selectively target the MPN cells, and these could have the potential to induce really nice disease modification, long-term remissions, or even potentially one-day cures. That's what we're really hoping for with these therapies. Obviously, it's very early days, so these are things that we have to see whether they're possible to achieve in the future. But there still remain some challenges. We know that the level of the target, the mutant calreticulin, remains low, particularly on the stem cells that we're trying to attack. And then there are differences between patients in terms of the shape and the level of the mutant calreticulin that sits there on the same surface. We also know that in some people, their T cells, their body's own immune cells, don't work as well as they should because of the underlying disease or because of previous therapies that they've received. Therefore, how well these agents work and which ones work best for individual patients still needs to be determined. And we also need to see, coming out of the clinical trials, safety data to understand the safety and any side effects or toxicities that can occur with these types of therapies. We already have now 4 phase 1 studies that are open. There's a vaccine therapy. This was updated at EHA, so I'll tell you about that. Unfortunately, that closed because it didn't show any efficacy, and I'll explain that at the moment. The second study, which did have some nice positive data reported at EHA, is a study led by Insight of a monoclonal antibody therapy, so an antibody that I'll discuss in a second. And the data that was reported was looking at an ET cohort. And then there is already also a trial open of an antibody that engages T cells. That wasn't reported at EHA, but I'll mention it anyway, because some of you may know about the study, and it is open and recruiting in the UK. And then there was some preclinical data reported again from Insight about another type of antibody that also engages the body's own T cells. So I'll cover those ones. And then I'll also cover this one shown here, which is a very clever type of antibody that also delivers basically a drug right to the MPN cells. So first of all, the MPN vaccine. So this was a study led by J&J. It was actually a really small study in the end. They designed to enroll 60 patients, but only 14 patients joined in the end, and then they ended up closing it early. So what they showed is this vaccine was basically built on an adenovirus backbone, and they showed that the patients were mounting immune responses. So this is before and after vaccine. They were mounting immune responses to the adenovirus bit of the vaccine, but when they looked to see if responses were being mounted to the mutant calreticulin, they didn't really see anything. So they saw small responses and then they went away again. So unfortunately, that showed that really this regimen was poorly immunogenic. It wasn't able to stimulate the immune system to clear the mutant CALR cells. And that was despite the fact that this vaccine was given with a different drug called a checkpoint inhibitor that we know is effective in actually different types of solid tumours. And that's a drug that tries to reawaken or ignite your T cell activity. So it was quite an interesting study design, and I think it's really important that the company published this negative result, because obviously it helps us learn about how these therapies can or cannot be effective, and studying these types of responses gives us more information to design future studies. So I think it's really great that J&J published that data and presented it at EHA. So the second study I'll cover then is this antibody study led by Insight. So this is also currently enrolling in the UK and open at Guy's in Oxford and in Manchester at the moment. So this agent is called Inca 033989, a rather long name. This is an antibody that basically blocks cells that carry the mutant calreticulin. The study's open, the trial's open for patients who've got high thrombotic risk ET, who failed another therapy, who've tried hydroxycarbamide, and that hasn't helped their blood counts. And it's also open for patients with myelofibrosis who've already received a JAK inhibitor therapy and again need further therapy beyond that. The data they reported at EHA was just data presenting responses in the ET cohort. So that's what I'll talk about in my next few slides. In terms of the study endpoints, so the study was designed primarily to look at safety, so to look at toxicities and adverse events that happened to patients on the study, but of course they also looked at responses. So first of all, safety, and of course when we first do first-in-human studies, the primary goal of these studies is to determine that the drugs are safe. And really beautifully, they've shown that basically the drug is very safe, and only a minority of patients do have side effects, and those side effects tend to be mild. And that's what's shown on this plot here. So there was only one patient who had to stop the study because of an adverse event. And now I think there are over 100 patients in terms of the total numbers of patients that have been recruited. So those are really good numbers. In terms of side effects, you can see them here: tiredness, chest infections, dizziness, headache, anemia, itchiness, diarrhea, and an increase in a blood parameter called the lipase, and a bit of nausea. And the percentages of patients experiencing these events are shown here. You can see that most of the bars are blue, which means these are very low grade adverse events. And of course, we don't know really whether these adverse events are related to the study drug or not. So safety is looking good. What about its efficacy? Does it work? So this plot here, we're looking at the platelet count. So here's the platelet count here on the y-axis of this chart, and this is time going on here. So the patients here are in screening, and then they're getting different doses. So dose number 1, number 2 of the study drug. So if you look at the numbers here, here's a platelet count of 1,000. That's really high. So most patients, the line here is showing that most patients had a platelet count of 1,000 when they were screened for the study. But then when they go on to the study, just after here, this is for the day they come for the second dose, really quite remarkably, the platelet counts really drop to just the top of the normal range, and then it's completely normalized by just after the second dose, before they have the third dose of drug. So what this is showing is really quite remarkably rapid control of the platelet count. And we also need to remember that these patients have tried one or even often 2 or 3 other agents to reduce their platelet counts, and that hasn't been effective. So this is a really nice response here in a group of patients who have got an MPN that's refractory to other standard therapies. Then potentially even more exciting, so what we're looking at now is the level of the mutation in the blood. So this is shown as a percentage decrease. So for example, this basically measures the number of cells or the proportion of cells that carry the mutation in calreticulin. And each bar here represents an individual patient. And what you can see really nicely is that almost all of them, apart from these folks here at the beginning, are going down. So they're below this x-axis, showing that the level of the mutation is decreasing. So 89% of patients had a decrease in the level, the variant allele frequency, or the level of mutant CALR. And in some of those patients, particularly at the higher doses in the dark blue, the level of decrease was actually quite profound, quite deep. So this is quite exciting. Some of these measurements were done very early, and with more time, we'll see whether these curves continue to deepen, whether these decreases continue to deepen. So what about the other types of antibody? So I mentioned already that some of the antibodies work differently. They don't block like the Incyte antibody, but they draw in the body's own T cells. And that's shown in this diagram here. So here's a body's T cell, here's an MPN cell, and the antibody is sitting here in the middle with these 2 arms to draw in the T cell to attack then the MPN cell. So there's already a study open, a phase 1 study that's currently recruiting in Oxford and Guy's and UCL. There wasn't any new data at EHA presented on this antibody, but we're expecting data to be presented at the American Society of Hematology meeting in December. So we look forward to that. So I've just put this slide here really to remind myself to tell you about this study. But what was presented was a similar antibody that also draws in T cells, but actually binds to a different part of the protein. And Incyte have made this antibody. They haven't tested it in patients yet. That trial's just opened in the US, and we hope to open it in the UK as well at the beginning of next year. And sorry, that's the dog. And what they're showing here is that the antibody can really effectively kill mutant calreticulin cells in a dish. So it's looking promising, and we hope to open that study as well. Then the final antibody that was presented at EHA was something called an ADC, so an antibody drug conjugate. So here's the antibody here, and you can see that there's a drug. This star here is like a payload that's attached to the antibody, and that's then delivered to cells which carry the mutant calreticulin. So this again has only been tested so far in the dish, and actually also in a mouse model of MPN by a company also in the US. And what they showed here was that using this antibody could kill cells in a dish and could slow mutant calreticulin positive tumours growing. So these are the mice here who had the antibody treatment. Their tumour size stays flat, so it doesn't grow. The patients who don't receive the antibody, their tumour volume grows. And that's when they inject tumours here onto the skin of the mice, basically on their back. So those are the antibody studies that were presented at EHA. It's a bit of a whirlwind tour, but really the key messages are that there was some really encouraging safety and efficacy data presented from the Incyte study, really confirming that mutant calreticulin is targetable. Patients had a really quite durable and rapid control of the platelet count, and most patients also had a reduction in the level of the mutation. The vaccine study was a really informative, negative, but informative result. And there's no evidence at the moment that the vaccine is boosting immune responses of our own bodies. Lots of exciting trials coming on the horizon with the other agents I mentioned, and really we're likely to need all of these. So patients are going to be different in terms of the types of antibody and how their disease responds. So I think it's really important that we support these studies, and thanks to all the patients who've taken part so far, and we hope to be able to in the future offer people with mutant calreticulin driven MPN a range of targeted therapies. So I'll stop there and look forward to the discussions.
Thank you very much, Beth. Just before we go on to the next speaker, can I ask you one of the questions that's come in online?
Yeah, sure.
And it's around how is the allele burden measured for patients?
Yeah, so that's a really good question, actually. So we can measure it either in the blood or in the bone marrow. So when patients go onto these studies, they tend to have a bone marrow biopsy. It's measured in the bone marrow, but we also measure in the blood. And then we do the monitoring in the blood rather than in the bone marrow to make it easier. So it's quite a simple genetic test actually nowadays. So it's just looking for the presence of that mutation in blood cells.
Thank you. Our next speaker is John Lambert, and he's going to provide us with an update on the MANIFEST study and the long-term safety of ruxolitinib. Great, thanks very much, Claire. Can you hear me okay? Very good, excellent. Right, so lots of stuff at EHA. I've got two sort of studies to present. One slightly longer one, that's MANIFEST 2, and another one's a sort of a poster relating to safety, so long-term safety of ruxolitinib. So they're both about myelofibrosis, and they both sort of center around ruxolitinib. But if I move forward, so this is the MANIFEST 2 study, and this was an update. So it was a 72-week update. The 48-week update was presented last year. And what we're looking at is whether for patients who've got myelofibrosis, who've never had a JAK inhibitor before, whether adding in pelabresib to ruxolitinib benefits them, whether it helps them in terms of the disease. So that's the question, is ruxolitinib plus pelabresib better than ruxolitinib alone? And I'll come on to a second what pelabresib is, but it's what's called a BET inhibitor. And better, of course, can mean different things to different people. So myelofibrosis, better might mean shrinking the spleen more. It might mean trying to make people feel better and reduce their symptoms. It may mean increasing hemoglobin and reducing need for transfusions, reducing fibrosis in the bone marrow, helping people to live longer and reducing the risk of disease progression. And all of this, hopefully, without creating too many side effects. So that's kind of what we're looking for.
John, so sorry, are you going to share slides?
Beg your pardon, sorry, I thought I was sharing. I had shared them. And
no, but you did a brilliant introduction, so that's good. There we go. We're at the end of the first slide. Perfect.
Sometimes things are better without slides. But anyway, so
yeah, exactly.
These are what we're looking for. So it's to see basically which of these different parameters are improved, hopefully, by adding in this BET inhibitor called pelabresib. And this is, I think, where a slide does come in helpful because it shows us what pelabresib does. It's what we call a BET inhibitor. So when we talk about sort of myeloproliferative neoplasms, we tend to focus on sort of what's called the JAK-STAT pathway. So this is what JAK inhibitors like ruxolitinib or momelotinib interfere with. So people who've got particularly, well, any kind of myeloproliferative neoplasm, whether it's a JAK2 positive one or calreticulin or MPL positive, this pathway here is overactive. And that basically drives DNA sort of synthesis down here in the nucleus to produce all of these different things which cause the problems that we see in people who've got myeloproliferative neoplasm in terms of too many blood cells or too large spleen or symptoms, etc. But there's another pathway which is sort of mediated by this protein called BET, which is a bromodomain and extra-terminal domain protein. And that is an epigenetic regulator, which essentially also contributes to DNA synthesis and kind of contributes to what we see by the JAK-STAT pathway. So what this study is looking at is whether if we block this bit with ruxolitinib and this bit with pelabresib, we can get better results in all these different parameters compared to just ruxolitinib by itself. There is a bit of data, I won't go into it now, but from what's called the MANIFEST or MANIFEST 1 study, but that was a phase 2 study. And there was this one, the one I'm presenting now, is what's called a phase 3 study. And this was double-blind and randomized. So patients were either, they had to fulfill these different criteria, which I won't go into now, but basically had to have myelofibrosis, never had ruxolitinib or another JAK inhibitor before, and a reasonable spleen size, amongst other things. And half of them got pelabresib, the BET inhibitor with ruxolitinib, and half of them got placebo and ruxolitinib. Because it was double-blind, nobody, not whether the patient or the doctor looking after them, knew what they were getting. And essentially, they got 21 treatment every 21 days in cycles, and then they were assessed at different time points. 24 weeks was a key one. And they looked at the spleen size. That's what SVR 35 means, whether the spleen reduced by 35% in its volume, also symptoms and side effects. So this was a key thing. This was spleen size reduction. And this is what we call a waterfall plot. And this is essentially all the patients lined up from the patients who got the best response, sorry, who got the worst response to the best response. Basically, the further, the lower they go, the further south they go, if you like, the better. And you can see this group here in the light blue are the ones who just got placebo with ruxolitinib, and the ones with the dark blue got pelabresib with ruxolitinib. But you can see these went further south, if you like. That means that they had more splenic reduction. That was Rux alone, if you like, with this, and then
with pelabresib, and the difference you might say is due to the pelabresib. You can see that all across the board pretty much there was more splenic shrinkage in the patients who got pelabresib, and this was a significant result, and it wasn't quite double, but it was almost double kind of the response rate. So this is, I think, quite a convincing response that pelabresib does shrink spleens quicker and more than just ruxolitinib alone. This is looking at symptoms, and essentially, if we look at that, this is the group at the beginning, at baseline, and then this is them as they move along to week 72, which is what is kind of being reported in this study. And again, in symptoms, you want to go as close to 0 as possible. And you can see both groups. The blue is the pelabresib with Rux arm, and this is the placebo and Rux arm. You can see that patients who got pelabresib perhaps was slightly lower than those who didn't, but it's not dramatic, and there's quite a lot of overlap between the two groups. So maybe there was, they described this as being a numerical improvement, but there wasn't a statistically significant improvement. I think that's quite important. So perhaps a little bit better, but certainly not dramatic in terms of symptom improvement. And this is things like fevers, sweats, fatigue, the kind of all the symptoms that people with myelofibrosis can get. Now here we're looking at their hemoglobin levels, and we're looking to see what happens to people if they start off with a median hemoglobin, an average hemoglobin of around 11 or 110, we tend to call it in the UK. And you can see the patients who just got ruxolitinib with placebo, as we would expect with anyone with ruxolitinib, their hemoglobin dropped. And it slowly improves after about 3 or 4 months, doesn't quite get back to baseline. Whereas patients who had the pelabresib didn't drop as far and did come back to baseline. And again, well, they also, on average, people in the pelabresib arm also needed fewer transfusions as well. So this is something that we'd seen in the original study, the MANIFEST-1 study that I alluded to briefly at the beginning. And this is suggesting that pelabresib, given in combination with ruxolitinib, may improve people's hemoglobin and may at least make them not drop too far. It may require fewer transfusions, but again, not statistically significant. So it's certainly quite impressive, but perhaps a bit more work to be done still. This is a degree of improvement in the fibrosis in the bone marrow. And again, this is a group that got pelabresib and Rux, and these are ones who got placebo. You can see if you just look at any improvement, whether that's grade 1, we grade fibrosis in the bone marrow from 0 to 3. And you can see 51% improved in the pelabresib arm and 28% improved in the placebo arm. And more people worsened actually in the placebo arm. So there's a suggestion here that pelabresib might improve or reduce the amount of fibrosis in the marrow, which is in essence one of the key parts of myelofibrosis. Again, quite encouraging. This is the side effects. I'm not going to go through it in detail. Basically, most of the side effects were quite similar. The one that wasn't was just what's called dysgeusia, which basically means kind of an altered taste. And more people who got the pelabresib arm, this is on this left side here, tended to get these taste changes. So that was something that we saw in the patients that we treated at UCLH, that they tended, or certainly a couple of them, got reasonably sort of significant taste changes. All the other side effects pretty similar. Probably a bit less anemia, as you might expect, in the arm that got pelabresib. This was something that people were concerned about a few months ago. There was concern that people who got pelabresib might have a higher risk of developing what's called accelerated phase, which is kind of the transformation towards leukemia. And if you look at this point, when the initial data was looked at, you can see 6.1 compared to 23%, so 6.1 compared to 2.3% had this evidence of progression. But as time went on, there weren't any new cases in the pelabresib arm. There were a few more in the placebo arm. So overall, it looks fairly balanced. So overall, quite a low rate anyway. So not many patients did transform to develop leukemia or sort of pre-leukemic phase disease. But it's maybe a bit disappointing. There didn't seem to be any benefit from the pelabresib treatment. So it didn't seem to slow down transformation in that small minority of people who do transform. And then these are the survival curves. Essentially, we want them to be as close to horizontal as possible. If they were completely flat across the top, that would mean that in this 33-year period, every single patient in this group
had basically remained completely well. They hadn't progressed, they hadn't died, they hadn't had any kind of disease sort of progression. Now you can see they're quite close to horizontal. They're not completely horizontal, but this basically shows over 3 years, not many patients did progress. But equally, there was no real difference between the patients who got pelabresib, which are the blue ones, and the grey ones who got placebo. So overall, most of the patients are doing well, but there wasn't really an improvement in kind of progression-free or leukemia-free survival. So, still, again, a bit of work to be done. These are their conclusions. They're quite sort of wordy. I've tried to go back to what I looked at originally. Spleen shrinkage, making people feel better, increasing hemoglobin, reducing fibrosis, living longer, and slowing disease progression. And what do I think? Definitely spleen shrinkage. There wasn't much in the way of symptom improvement. There was definitely some hemoglobin improvement. There was some fibrosis, or it wasn't dramatic. There was some. It didn't seem to make people live longer or reduce the rate of disease progression, but both groups seemed actually to do pretty well. And the side effect profile was pretty good, apart from that taste issue. So is it better? I think the jury's still out. There is likely to be a new, what's called Manifest 3 study, which will be opening sometime in the next few months. And that'll be looking at patients who are very, very symptomatic to see whether pelabresib is particularly good for that group of patients. So that may be coming to a centre near you. So if you've got myelofibrosis and haven't had a JAK inhibitor, then keep an eye out for that study. So that's the main study. This is a very quick piece of work. Well, no, it's an awful lot of work, which took someone an awful lot of time, but I'm going to present it very quickly. I should phrase it carefully. So this is actually really impressive work coming out of Spain. It's a lot of words, so what I'll try to do is very briefly summarize it. So 65 different healthcare organizations. This is huge, almost 17,000 patients with myelofibrosis. So you'd almost never see this kind of size of cohort in myeloproliferative neoplasms, which are relatively rare. And they divide them into 3 groups. Most of the patients hadn't had a JAK inhibitor. 2,500 of this group had had ruxolitinib for less than 3 years. And then the rest had had it for more than 3 years. And they tried to see if, in terms of long-term side effects, there was a difference between people who'd never had it, those who had it for less than 3 years, and those who had it for more than 3 years. And this is what these are the relative risks, and essentially if it's more than 1, and certainly if it's more than 2, you sort of think, this could be something we need to look out for. And you can see these are the patients who had it for more than 3 years compared to people who didn't have it at all. So these are the things I'm really going to focus on. And you can see there was a relatively increased risk, not hugely increased risk, but it was about 2 to 2.5 times higher in people who'd had ruxolitinib for more than 3 years of getting non-melanoma skin cancer. These are things like squamous cell and basal cell carcinoma. And also shingles, herpes zoster shingles. So these are things we've known about, so they're not new. They give us an idea of how big the risk is, if you like. And interesting, in patients who've had it for less than 3 years, there was a slightly increased risk of certain infections like pneumonia, urinary tract infection, and sepsis. Not dramatic, but it was what we call significantly increased. So basically telling us that in this really huge, impressive, real-world evidence cohort of patients, there was a higher risk of these non-melanoma skin cancers and shingles, and probably a slightly higher risk of bacterial infections. But they happened slowly over time. It didn't seem to be a particularly high-risk period. It just seemed to be something that gradually accrued over the years. Overall, I think it tells us that ruxolitinib is a safe drug. We need to be aware of the side effects, but certainly there's nothing here in this really big, quite long-term study that really makes me think, oh my gosh, there's new concerns we need to think about. These are all things that I think we all know about. And for me, it's a relatively reassuring kind of piece of work, but it does tell us that when people start on ruxolitinib, we do need to be on the lookout for these. I think that's enough from me. So I will try to now stop sharing. Hopefully I can do that better than starting sharing.
I'm sure you definitely can. Thanks so much, John, for that. Useful to highlight that we will have to do Manifest 3, having done Manifest 1 and Manifest 2. There are some other first-line studies, aren't there, in the UK at the moment? So probably worth just highlighting those. Didn't know if you wanted to maybe do that.
Certainly, we've got open the CARTOS, which is the it's called POESIS rather, which is supported by a company called CARTOS, and that's looking at a drug called navtemadlin. That's a very interesting sort of looking study at people who are initially treated with ruxolitinib, but then after a few months, we look to see if they're responding well enough, and if they're not, they randomised to either get this new drug or not. So that's really, I think, quite a nice way of looking at it. not giving everyone the drug, but looking at people who potentially might benefit, whereas people who are doing really well in ruxolitinib just carry on with ruxolitinib. There's a number of other studies which we're doing, but are there any ones you wanted to mention, Claire?
Yes, I think just to call out the one with selinexor. So just talking about frontline studies, the other frontline study we currently have is with selinexor, and Jen O'Sullivan's going to be talking about selinexor later. But thank you so much, John. And Claire is going to introduce our next speaker, who's well known to everyone, but please go ahead, Claire.
So our next speaker is Professor Adam Mead from Oxford.
Right. Hello, everyone. Can you hear me okay?
Yes, we can see you're in clinic as well.
Yeah. Yes. Finished clinic, thankfully. I don't have a patient sat next to me. Right. Let's see if we can get this working. Can you see my slides?
We can, yes, and they're in slideshow now, yeah.
Great. Okay, good. Okay, I'll just talk for about 6 or 7 minutes to highlight a couple of interesting abstracts that were presented at the European Hematology Association meeting. Apologies, they are scientific slides, as Claire mentioned at the beginning, but I'll try and explain them to you. So the first abstract I'm going to tell you about is this early phase study. So a phase 1/2 study means that it's quite an early study of a drug in development, this drug, divesiran, which we don't need to see all the details of this, but it's a drug being developed in polycythemia vera, and it's using a really exciting and interesting new technology that can alter the expression of certain genes. This is a horribly complex slide that I will do my best to simplify. Basically, what this is summarizing is that this drug treatment works in the liver to lead to the increase in the level of this particular protein called hepcidin. And this is going to be an increasingly important axis to target in polycythemia vera. There's a number of drugs targeting this particular kind of pathway, and this particular protein, hepcidin, is really crucial for regulating iron. And those of you with polycythemia vera will know iron is absolutely crucial to the production of red blood cells. And in people that have regular venesections to control their red blood cell level, they can ultimately end up iron deficient. And so these drugs that increase hepcidin levels are a way to kind of restrict the availability of iron for the red blood cell production, and thereby prevent excessive red blood cell production in polycythemia. So a kind of new way of controlling the hematocrit. It's very, very clever the way it works. I won't talk through the details for long, but just in brief summary, it's an injected drug under the skin that then cleverly finds its way into the liver cells and then alters the expression of a certain gene that leads to this upregulation of hepcidin that then reduces the availability of iron without someone needing lots of venesections, or so we hope. So this is an early phase study, phase 1/2 study. So it's initially dose finding. You can see patients receive injections once every 6 weeks, so not a high burden of injections required. And these are polycythemia vera patients who are requiring regular phlebotomies or venesections. And this is probably the key slide to show you. Each of these red blobs here represents a venesection. And during the treatment period, you can very clearly see across all the cohorts the number of venesections really dramatically decreasing, which is, an important treatment goal in people with polycythemia. Here's a kind of graphical representation of the control of the hematocrit with this drug. You can see the hematocrit in percentage terms improving. And as expected for the mechanism of action, the hepcidin level increasing, one of the things we've noted with this class of drugs is it can push up the platelet count, which we can also do. Venesections can also increase the platelet count by restricting iron. So that's something we need to watch for. In general, the side effects were reasonably tolerable for patients. There were some injection site reactions, but largely these were pretty mild side effects. So it's a completely new class of drug. There's 3 different drugs coming through in this area that look interesting. And essentially, this is a way of increasing hepcidin to the lower the hematocrit and therefore get the target hematocrit down into the target range in polycythemia vera. And there are a number of studies coming to the UK soon with this class of drug for patients with polycythemia vera. The second abstract I'm going to tell you about briefly is this very large study of patients with essential thrombocythemia now, too many platelets, with this particular mutation. Many of you might have heard of the JAK2 mutation and maybe the calreticulin mutation, but this is the kind of third type of what we call driver mutation in patients with MPN, but it's like the less well-known one because it's less common. JAK2 occurs in, ET in about 50 to 60%, calreticulin mutation in 20 to 30%. The MPL mutation is about 5%, which makes it pretty impressive that this group, including a number of us from the UK, pulled together 300 patients with this particular disease. There are certain mutations that are more common. This particular one with this particular kind of code name, W515. And the average age, worth noting that as I move on to the other slides, is just about 60 in this very large cohort. And bearing in mind people were diagnosed at the age of 60, you can see this is how long people are living with the condition. These are years on the x-axis here. So you can see after 20 to 30 years in people with an average age of 60, still the majority of people alive after quite prolonged periods of time, which is quite encouraging and shows us how indolent a disease, how slowly progressive a disease ET can be. There were some ways of predicting people who might have a type of MPL mutation, essential thrombocythemia, more likely to progress. So patients with a previous blood clot or with a previous bleeding event, or with more bone marrow scarring, bone marrow fibrosis at diagnosis, they were all more likely to show progression and reduce survival. And also people presenting with a particularly high platelet count. But nevertheless, overall, really quite a lot of evidence this is quite a slowly progressive form of blood disorder. And this is most definitely the largest cohort of these patients reported to date. So really quite informative for this patient group. Thank you very much.
Well, that was great, Adam. Thank you so much. And so important to be able to collect data in that way, isn't it? Because the MPL mutation is quite rare, isn't it?
Yeah, these are quite rare, and this shows you how really teams of doctors working in this area really try and join forces for these rare conditions and pull together as much information as we can, so that then we can learn what happens to people over time and inform people in the most detailed possible way in clinic. So we do a lot of these so-called observational studies, and many of you coming through the clinic will be approached to consent for various research projects, giving your informed consent to share your data, and this is why it's so important.
Yeah, perfect. And could you just comment on a question that came in the chat, not in the chat actually, before the webinar, before we introduce the next speaker, which is there JAK2 faulty gene corrective therapy yet?
Gene therapy.
Yes, so Beth has put a comment in the chat about the mutation-specific inhibitors, but maybe you could expand on that, but also quick chat on gene therapy.
Yeah, it's very interesting, actually. It's something we're working on in the laboratory and will be reporting at the ASH meeting. It is possible to do a selective gene editing treatment to remove the JAK2 mutation. People have published this in the past, and and there are new approaches for doing this with increased efficiency that we're going to report at the ASH meeting. I think the challenge with this approach, there's a number of challenges, but the most difficult thing is how do you deliver all the molecular machinery to do that gene editing? How do you deliver that to the blood cells? And it's actually very complex to do that. And final comment, without taking too much time, is because these are what are called clonal conditions. The challenge is you have to remove 99%, maybe over 90% of the cells carrying the mutation in order to really set back the clock a number of years, I think, using this kind of approach. So I think that's going to be the challenge. So technically, it's definitely possible to do that, and it's an exciting new technology without question. Is this close to the clinic yet, or early phase clinical trials? No, it is not yet. There are other gene therapies and gene editing approaches that are in the clinic, for example, for sickle cell disease, but we're a little way off doing this in JAK2 mutant MPN.
Thanks very much, Adam, and thanks for joining from your clinic, and hope to have more chats on the panel in a few minutes. So over to Claire to introduce our next speaker.
Thank you. So moving on with our next speaker, it is Dr. Jennifer O'Sullivan, who's a consultant hematologist at Guy's Hospital.
Thank you, Claire, for the kind introduction. I hope everyone can hear me okay.
Yes.
Yeah, perfect. Sorry if there's any background noise. So really glad to be here this evening. It's a really great session so far. So I'm going to cover, there's lots of new exciting therapies in MPNs across the board really, but particularly in myelofibrosis. And in the interest sort of time, and there's been lots of other speakers covering interesting agents, I'm going to focus very briefly just to draw your attention to two quite exciting compounds and some of the data updates that were presented at EHA. So the first is the TGF-beta type of ligand agent called elritercept. And then the second is selinexor, which is an X4 or XPO1 inhibitor. And I will go through sort of what the mechanisms of these and how relevant they are in myelofibrosis. So the first is elritercept, and there is an ongoing phase 2 study called the Restore trial. This is a slightly earlier study treating patients with myelofibrosis, either with single agent elritercept or in combination with ruxolitinib. Briefly, what is elritercept and what is it targeting? So it's thought that this is an agent that blocks some of the downstream ligands and pathways of TGF-beta. So we know that TGF-beta is an inflammatory marker that's increased in patients with myelofibrosis and is particularly important in the development of the fibrosis process that is ongoing in these patients. And some of the laboratory work has shown that elritercept can improve erythropoiesis and blood production in mice models, and also it can reverse some of the abnormalities that are associated in myelofibrosis. And also they've been shown to increase the platelet count. So quite a potentially interesting agent in myelofibrosis. And I'm going to show some of the updated data that was shown at EHA. I won't dwell on it for too long because this was presented also at ASH, and we presented this in the ASH highlights in January to the MPN Voice group. But this is an outline of the study schema. It's a very busy slide, so not to worry about all of the detail on it, but this is the standard sort of outline of a trial schema. What are the eligibility criteria for patients? And essentially, patients who were anemic or transfusion dependent, so a reduced hemoglobin, were eligible for the study. And at this point in showing the data, there were 73 participants evaluated. This is looking at the characteristics of the patients and to really highlight that this is a patient group that had significant anemia and required transfusions. Quite a number of patients had significant thrombocytopenia, and the majority of patients actually had large spleens and had symptoms. And most patients had many had prior exposure to ruxolitinib. Looking at these bar charts, this is first looking at improvements in hemoglobin. So in green are patients who were treated only with elritercept alone, and in blue are patients who were given the combination of elritercept and ruxolitinib. And you can see here the increase in the bars, improvements in hemoglobin, and across both monotherapy and combination, there is increases in hemoglobin with elritercept. And similarly here, there's a reduction in transfusion burden in patients who are transfusion dependent, again with single agent therapy, but maybe even more impressively with patients who are on the combination. Although you can see here that there was quite, there were more patients on the combination of the two drugs. And looking at spleen sizes, there were a smaller number of patients to evaluate, but you can certainly see in the combination arm, there were more often patients having a reduction in their spleen size, which is really encouraging to see. And in parallel with that, we also, we know that looking at symptoms and improvement of symptoms is really important in myelofibrosis. So as well as spleen response, there was an improvement in symptom response, maybe not as impressively, but certainly was present more often on the combination. So the takeaway from this study, this phase 2 trial, is that the drug, I haven't shown the safety data, but this drug is very well tolerated. It's a monthly subcutaneous injection, tolerated both on its own or in combination with ruxolitinib. It potentially, particularly, may be beneficial for patients who have anemia, and also maybe actually looking at the disease process with reducing spleen and improvement in symptoms. So that's commenting on elritercept, and moving on to selinexor, which is an XPO1 inhibitor. So what is XPO1? So this is a gene coding for a protein called xporrin, and that shuttles proteins in and out of the nucleus of a cell, which you can imagine is quite important for a cell and for a number of pathways. And various laboratory work has shown actually that this drug and targeting this pathway can inhibit a number of really important processes involved in myelofibrosis. So reduction of the STRAT pathway, reduction of NF-kappa B, which is another pathway that is shown to be abnormal in myelofibrosis, and a number of other processes. Looks quite complicated, so I won't dwell on it, but just to illustrate that this agent potentially may target a number of important different pathways, which is quite exciting and to see. So presented at EHA as a poster was an earlier study so it's a phase 2 study again, focusing on selinexor as a single agent. So this was an international study with a number of sites internationally, and patients who had been exposed to JAK inhibitors, not necessarily ruxolitinib, also fedratinib, were randomized to either selinexor on its own or physician's choice. And patients, if they have on physician's choice had an increased spleen or disease progression, they were able to cross over to selinexor. This was quite a small study, so limited to 24 patients. There were 12 on either arm. I'll come on to a comment here about the phase 3 trial at the end after I show this data. But even though these are small numbers of patients, you can actually see here again another bar chart plot showing the data, but there are more often reduction in spleen volume and symptom improvement. So this is looking at spleen volume, but there's more often a reduction in the selinexor treated patients. And I think this is quite impressive because these are patients who are ruxolitinib exposed, and oftentimes if a patient has been treated with ruxolitinib and failed ruxolitinib, they're often quite resistant to other therapies and very often don't have spleen responses. So to see a spleen response with a single agent therapy like this is quite encouraging to see. And again, there was improvements in hemoglobin on the monotherapy arm compared to patients who were treated by physician choice. So that could be a variety of therapies. And again, this is small numbers, but this is encouraging. Looking at side effects and adverse effects, which is very standard in these clinical trials, called here treatment emergent adverse effects. There's a long list listed here, but really to highlight that there was no very serious adverse effects leading to discontinuation of the drug. There's been sort of anxiety across the field about nausea and vomiting, which was a problem in previous when this drug was used in myeloma, but the dose has been reduced and it hasn't really been seen as a significant signal in the trials in myelofibrosis thus far. So to conclude in this, even though this is a small study, using this to show early encouraging signs of reduction and was well tolerated. And that brings me on to highlight to you all the phase 3 trial. So this is a slightly later study where the intervention selinexor is compared to placebo. And this is for patients with myelofibrosis who have not been exposed to a JAK inhibitor, so they haven't received treatment, and they are randomized to either receiving ruxolitinib plus selinexor, the dose of 60 milligrams, or ruxolitinib and placebo. And this is open in the UK and internationally currently, and hoping to complete enrollment by autumn time. So this study has been well recruited and almost fully recruited, and hopefully next year that we'll start getting a signal about the results of this study. But this is sort of quite exciting to see combining ruxolitinib with this novel therapy. And again, the primary endpoints are looking at spleen volume reduction and symptom response. Interesting biomarkers such as reduction of fibrosis. We have a second parallel study opening called Sentry-2, which is a novel phase 2 trial, not again looking at selinexor as a single agent therapy in patients with thrombocytopenia. So starting with selinexor as a drug, add on a JAK inhibitor, so slightly different style. Typically, other studies have started with JAK inhibitor therapy and add on a second agent. It's quite an interesting design. And patients who have thrombocytopenia, there's often quite limited options in terms of treatments, and they are usually excluded from trials. So quite encouraging to see that we have a trial available for patients who have thrombocytopenia. And this is currently open in the UK and potential enrollment. But that's all I wanted to say. In the interest of time, I'll finish here and happy to take questions. Thank you. Apologies about the door slamming.
We didn't hear the door, but your internet
Right.
was a bit wobbly, but the slides were great.
Oh, apologies.
And we heard most of you, Jen.
Okay.
We heard most of you. Claire, please go ahead.
So we'll move on with our final talk this evening, and this is actually a video prepared by Dr. Alessia Khan, who will actually join in the panel discussion a bit later.
Good evening, ladies and gentlemen. My name is Alessia Khan. I'm a consultant haematologist working in Leeds in diagnostics and MPN. It is my absolute pleasure to be here with you this evening to present the Surpass ET trial presented by Dr. Harry Gill at EHA. Disclosures. Essential thrombocythemia, as I am sure you are all very familiar, is a myeloproliferative neoplasm driven by a mutation in either JAK2, CALR, or rarely MPL. It is characterized by the fact that the driver mutation stimulates the overproduction of platelets, and this leads to increased risk of thrombosis, that's blood clots, bleeding, and potential progression to myelofibrosis, and in a very small subset of people, progression to acute myeloid leukemia. The Surpass ET trial was designed to compare the safety and efficacy of ropegylated interferon alpha 2b, also known as Besremi, and enaglaride in patients treated after experiencing resistance or intolerance to hydroxycarbamide. This is the trial design. Males and females over the age of 18 were included if they were deemed high risk by either age over 60 or prior thrombosis. Patients had to be intolerant or resistant to hydroxycarbamide, which is defined as not having controlled blood counts or having undesirable side effects. And the patients must not have been treated with any interferon previously. 174 patients were randomized in a 1-to-1 fashion so that there were roughly 2 equal groups. The groups had similar numbers of males, females, similar ages, driver mutations, and so on. The patients on Ropeg were started at 250 micrograms every 2 weeks, so that's 1 whole pen, and then after a total of 4 weeks, they were increased up to 500 micrograms, which is 2 whole pens. The dose was high so that the study could reach its endpoints in the specified trial period. The enaglaride was given with a median dose of 2 milligrams daily. The primary analysis was performed at 9 and 12 months after the study began. The primary endpoint was blood count control, improvement in large symptoms, no progression of disease, no bleeding, and no blood clot episodes. The secondary endpoints included a reduction in the driver mutation, so that means a reduction in the VAF level of the JAK or the CALR mutation, improved overall symptom score, and safety. The primary endpoint was met in terms of the ELN criteria. Out of 91 patients on Ropeg, 42.9%, so nearly half of patients, achieved control of the blood counts, an over 20-point reduction in the total symptom score, no blood clots, and no disease progression to myelofibrosis or acute leukemia after 9 and 12 months. This was only achieved in 6% of those taking anagluride. As an important secondary endpoint, the molecular response was examined. This is the reduction in the JAK or CALR VAF. Here you can see that 1/3 of patients taking ROPEG achieved molecular response after just 12 months of treatment. And breaking this down, 27.8% achieved a partial molecular response, which was a reduction by 25 to 50%, and 2 patients achieved a complete molecular response where the JAK level was undetectable. For patients taking anagluride, none of the 83 patients achieved any molecular response to this level. Here we can see the individual changes in the driver mutations for all patients. On the left-hand side are those patients with a JAK mutation. Anything above the line is an increase in the VAF, and anything below the line is a reduction in the VAF. The patients treated with ROPEG are in green, and you can see much more green below the line indicating the reductions in the VAF. 70% of patients on ROPEG with a JAK2 mutation achieved a reduction in the VAF. The numbers are much smaller in the CALR group on the right, but the similar pattern is seen. Where symptoms are concerned, the patients on ROPEG, again in green, have a higher improvement in the symptoms at 12 months compared to those on anagluride in black. And this is evident when you divide the symptoms into 25% reduction in symptoms and 50% reduction in symptoms. Another secondary endpoint is thromboembolic episodes, which includes heart attack, stroke, PE and DVT. The ROPEG group, out of the 91 patients, there was only one such event, which was a PE. That's 1%. And in the anagluride group of 80 patients, there were 8 events, which is 10%. Lastly, looking at the safety, there were less treatment emergent adverse events in the ROPEG treated group, which overall was 23%, compared to those taking anagluride, which was 33%. Of those patients, 5% on ROPEG discontinued the drug, compared to 20% on anagluride. The adverse events in the ROPEG treated group were things like deranged liver function, anemia, itching, compared to the anagluride group, who experienced heart palpitations, headaches, peripheral edema and dizziness. In conclusion, ROPEG showed superior efficacy compared with anagluride as second-line treatment for high-risk ET. It represents a potential new therapeutic option for patients with ET. We do routinely use ROPEG for patients with ET, as you know, but it was initially designed for use in polycythemia, and there are not as many trials studying its use in ET, so this is very useful. Hello again. My name is Alessia Khan, and it is a pleasure to present to you a trial called P1101 MF, presented by Dr. Harry Gill at EHA. Even in lower risk myelofibrosis and pre-fibrotic myelofibrosis, this is when the reticulin fibers in the bone marrow are grade 1. There are a number of treatment needs. Thrombotic, so blood clot and bleeding complications, can occur in up to 48% of patients over a 15-year period. Survival in pre-fibrotic MF is long at 14.7 years, but this is significantly lower compared to patients with ET. Disease progression to more advanced myelofibrosis can occur after an average of 7 years. This was an open label, that means the patients knew what they were taking, prospective trial, so that means happening in real time. The eligibility criteria included patients with pre-fibrotic MF and overt and secondary MF, so that overt means with the fibers grade 2 to 3, and secondary MF means after the previous diagnosis of ET or PV. Patients required treatment due to symptoms or their big spleen and had never been treated with interferon. Patients were started on 250 micrograms of Ropeg every 2 weeks and titrated up to 500 micrograms every 2 weeks by week 4. The dose was then reduced if required due to side effects such as low blood counts. The primary endpoints were hematological response, so that means blood count control response, and safety. Secondary endpoints included changes in the blood counts, improved symptom score, improved spleen size, incident of blood clots and bleeding, disease progression to more advanced myelofibrosis or acute leukemia, change in VAF, and the acquisition of new mutations. 71 patients were enrolled with a low dropout rate and treated until 104 weeks of treatment. 70% of patients had the pre-fibrotic MF and 30% had overt or secondary MF. Most patients, 68%, had a JAK2 mutation and 27% had a CALR mutation. Only one had an MPL mutation, as this is rare. This shows the treatment duration of every patient, with only 10 discontinuations of Ropeg. 6 were due to disease progression, 3 due to adverse events, and 1 due to removal of consent. These plots show the white count on the left-hand side, with pre-fibrotic MF in blue and overt and secondary MF in orange. There's a slight reduction at the start and then a plateau, and this is also seen for the neutrophils on the right. Similarly, hemoglobin seen on the left-hand side with pre-fibrotic MF in blue and overt and secondary MF in orange. There's a slight reduction in the hemoglobin at the start, and then it plateaus. With the platelets on the right, these start off at a slightly higher level and reduce into the normal range and then remain in the normal range throughout. Blasts, which are the immature cells seen in the blood in some patients with overt and secondary myelofibrosis, are on the left-hand side, and you can see very promisingly a reduction in these cells, and then they plateau to follow the same low level as pre-fibrotic MF. LDH is on the right-hand side. This is a good marker for disease activity, and it can be clearly seen to reduce over time in the overt and MF secondary MF group. As far as symptoms are concerned, 42% of patients achieved symptom reduction at 24, 48 and 104 weeks. Anything below the line on the charts at the top is a reduction in the symptoms. At the bottom, all the symptom scores are broken down at the various time points of 24, 48 and 104 weeks, and in all the different symptom categories at 24 and 48 weeks there is a reduction in the symptoms. Only 14 patients had a big spleen to start with, as splenomegaly is not a prominent feature in pre-fibrotic MF. Of those 14 patients, 9, so 64%, achieved a spleen reduction size. This is a very busy slide detailing the molecular responses, but essentially the take-home message is that at 24 weeks, 53% of patients had a molecular response, and 70% of patients at week 48 had a molecular response. Very interestingly, some patients had additional mutations, which we do see in myelofibrosis, and some of these patients had a reduction in the size of these mutations, which is also very encouraging. The treatment was generally very well tolerated with few significant side effects. There were only 3 discontinuations, 1 due to itching, 1 due to liver test problems, and 1 due to tiredness. In conclusion, Ropeg was found to be safe and well tolerated in early and low risk MF. It produces durable control of the blood count, symptoms and molecular responses. There is a suggestion of possible disease-modifying potential as seen in the reduction in the bone marrow reticulum fibers and a reduction in the molecular responses of driver mutations and other mutations. The group have designed a phase 3 similar version of the trial, which will be bigger with a placebo arm for comparison. We will wait in anticipation for the result of this trial.
Well, that was great. I'm particularly grateful to everyone who's joined and all the speakers who've made efforts to make slides or record them. Alessia in particular has been multitasking, going to a school concert, and she's now with us online. So I'm going to ask all the speakers to turn their cameras on. And we're just going to do a quick panel discussion. I realise we're a little bit over time, but as you can see, we have a lot of really exciting information from the EHA meeting. So we have one question for each speaker. And Adam, if you're still on, I'm going to come to you with the first question. Yeah, you're still here and you're still in clinic. Is it possible, Adam, to trace the lineage of the first mutated cell for MPN?
Oh, that's a very good question. Well, it is. There's some really interesting work, I guess, primarily carried out by the team in Cambridge, where they've done exactly that. Really tried to trace back the life history of the MPN cell. You know, when and it originally acquired the mutation that ultimately causes the disease. And we've also done some work in this area. And the remarkable finding is that the original mutation in JAK2 or calreticulin probably occurs many decades before the actual disease. Now, in terms of tracing the lineages of those cells, that is more tricky. You can only really genetically go back in time by sequencing the cells. So yes, it is possible to do that and kind of do, you know, almost detective work to work out how long that mutation has been there and how long it's taken to cause the disease. And tracing the lineage of the mutation is a little bit more difficult. Hopefully that answers the question.
Yeah, I thought it was a great question, and I know you're more than equipped to answer that one. Yeah, absolutely. Claire, I think you've got a question for Alessia.
Yes, great. So Alessia, we've got a question that's come in beforehand, and it's about a lady who's diagnosed with ET, and she's read a bit about bomedemstat and is asking when it's likely to be available in this country and via the NHS.
Bomedemstat is a different drug that's currently being trialled for ET, and there are going to be 2 studies looking at this drug, which is a tablet drug for patients either with newly diagnosed ET or patients a bit like the Surpass ET trial that Alessia presented. So those are currently studies that are open on the portfolio. I'm not sure how many hospitals have got them open. They're just opening, I think, aren't they? Yeah, I can see nods from my learned colleagues, say that's good. Maybe, Alessia, we could ask you about tolerability and when should everyone be on interferon, or is hydroxyurea good enough? Quite a lot of chat on that in the chat, yeah. And maybe about tolerability in ET. I saw John ask that question as well.
Well, in the Surpass ET trial, only 5% of patients on the trial discontinued the drug, and that was compared to 20% of patients on anaglyride who discontinued. So I think it has a lot of, still has some bad press from when interferon was given 3 times a week. But this is really much better tolerated. The Ropeg that's given every 2 weeks, you can start at a slightly lower dose, and then the people tend to get used to it very well. And then the dose can be increased. And in real world practice, we're seeing that it's very well tolerated. So sometimes people get slightly deranged liver function tests, but that can often just settle over time, even with not reducing the dose, or the dose can be reduced and they recover. And I think hydroxycarbamide is still a very useful and valuable drug in the place where interferon isn't tolerated. Then we've got that alternative option.
And just because the Surpass ET study is really important, and just what we don't tend to use anagrelide as a first-line drug in the UK, or even often as a second-line drug. What would you say to patients about anagrelide? I know you treat loads and loads of patients in your clinics.
We do, but very, very few on anagrelide, actually. I think, well, I think if patients have been intolerant of PEG interferon, I think it's still worth trying RoPEG now it's available, because some people will be able to tolerate RoPEG rather than PEG, and especially if at low dose. And one thing I found that is really helpful is to, if the platelets are really high, give a little bit of hydroxycarbamide to get them under control, and then start the interferon. That can sometimes work, because sometimes patients feel really anxious when the platelets are very high, and just seeing them a bit controlled and then start the RoPEG, you're not having to give a really high dose of RoPEG at the beginning. But I think if all those things fail, then there is, you know, that option for anagrelide. We don't really favor it in our clinic anyway. And, you know, there are some data coming out, which we did present some data at ASH, which showed it might not be so preferable for patients with CALR mutation. So we need some more data about that.
Great. Claire Woodley, I think you might have a question for John now.
Hi, yes. So we've had a question come in about, and I suppose probably in the context of the availability of more trials now for MF, but what are the challenges around deciding when the right time to proceed with a stem cell transplant is for a patient?
I mean, that is a complex question. So, I mean, I think first of all, I mean, the overall kind of question is, will that individual person benefit from having a stem cell transplant or not? And that is going to be a very kind of complicated equation in some people, because you're trying to work out what are the risks and possible complications of their disease, and what are the risks and possible complications of their transplant, and also what are the benefits of the transplant. So we generally will consider a stem cell transplant if somebody's got high risk myelofibrosis. And conventionally, we tend to think about those who've got what we call intermediate to or high risk, but there's different ways of calculating that. And that's something, if you've got myelofibrosis, to discuss with your consultant. But also, people have got to be sufficiently fit for that. And that's all kinds of different fitnesses. It relates partly to age, but also to kidney function, heart function, and that kind of thing. And also the availability of a donor, because obviously to have a stem cell transplant, you need to have a donor to be able to get the stem cells from. So there's a variety of different factors which will affect that. And what we'll do is, if somebody is, we think, fit enough, so generally it tends to be people certainly sort of under the age of 65 or 70. There isn't a hard cutoff. It depends very much on how fit and how well somebody is. But generally, as you go older, the risks tend to get higher from the stem cell transplant, and the availability of the donor and how close a donor that is, how close a match that person is. And then if they've got a potential donor and they're fit enough, we will then have a conversation about stem cell transplantation. And some people, even if we think that actually in the longer term they may benefit from it, once we've talked about it, actually decide that's not what they want, or that's not what they want now, because they've got, you know, other life kind of issues, whether it's work or family or whatever. So there isn't a right or a wrong. It's about trying to have that conversation. When is the right time? When is somebody likely to benefit from it? But also, where does it fit into an individual's kind of day-to-day life? I think that's probably as kind of specific as I can be, because it is a very individual decision.
Yeah, no, I think that's great, but it's so important, because in the context of having so many clinical trials and things like, I think it's often a very difficult one, and I know one that you do really well. Claire, did you have another question?
Yeah, so we've had quite a few questions around JAK2s and allele burdens, and so I was going to ask Jen, are there any studies currently underway to confirm the link of the allele burden to disease progression, and therefore guide us in more frequent measurements of these levels?
Thanks for the question. It feels maybe slightly primed. Well, so in the last 12 months, the PROUD PV data, which is quite nice data from France, did compare rope-regulated interferon compared to standard therapy and did show a correlation with a reduction in the JOC2 allele burden and improved what they call event-free survival. So that is looking at people who are alive without having a thrombosis, progression to myelofibrosis or hemorrhage. And these were relatively small numbers, but it did show that patients who were on rope-regulated interferon more often had a molecular response, so over half reduction in the proportion of the JOC2 mutation, and that was associated with better outcomes. Now, that hasn't been proven replicatively across myelofibrosis or in ET, and as you say with that question, I think larger studies are needed. So Alessia, who is also on the call with myself, we are submitting a proposal to look at this in a larger cohort of patients, which I think maybe a number of the patients who are on the call might know about and might have helpfully completed our survey. So we're hoping that in the next 6 to 12 months, we will be able to obtain funding to open the study in the UK. So that would be looking at tracking the allele burden in JAK2, CALR, and maybe if there was any MPL mutated patients across MPNs, so with PV, ET, MF, and tracking those annually, prospectively, so looking forward, but also stored samples and trying to track that with outcomes to see if we can understand, just like you've asked in the question, if there is a correlation with reduction, but also if there's a correlation with increasing and maybe disease progression. So if someone is on a therapy and their allele burden 5 years, 2 or 3 years later increases, is that associated with progression, say, to myelofibrosis, and would that justify a change of therapy? We don't necessarily know the answer to that yet, but we're really hoping with this study we'll be able to do that. So we're currently in the trying to find funding stage, and we're optimistic. So that will be my answer.
Brilliant. So, and as I put in the chat, it was a real question asked by a real patient who pre-submitted their question.
No, I figured it was. I was joking.
Perfect. So actually, going to close by coming to you, Beth. Maybe you could just quickly comment on momelotinib. Lillian's put a question in the chat, but what I really wanted to ask you was, I think what everyone was talking about at EHA was the CALR therapies, and we've all worked really, really hard to get those here for our patients in the UK. So what I'd like to understand from you is, what do you hope to see with these CALR therapies, and are they disease modifying?
Great. Yeah, thank you. That's a nice question. I'll maybe just quickly say one word about momelotinib. Shall I just have that question
answered?
Yes,
please. That would be great.
For people who aren't aware then, momelotinib was licensed this year, so another JAK inhibitor licensed for patients with myelofibrosis, very similar to ruxolitinib, but with one important difference, which is that it's licensed for patients who also have anemia. It tackles the anemia by improving the availability of iron for the body to make red cells. So we see that at least about a third of patients who receive momelotinib do have an anemia benefit. So that is the difference between momelotinib and ruxolitinib. So if that's of interest, then maybe speak to your local team about opportunities for momelotinib. And like ruxolitinib, it's also good at controlling spleen sizes and symptoms, but has a slightly different side effect profile. So that's one thing to also bear in mind. So to stick to time then, what do we hope to see with the CALR targeting antibodies? Well, I think what we really hope to see is something that goes beyond what we see currently with other drugs that we have for patients with MPNs. So I think what we're hoping for is to see benefits that go beyond controlling blood counts, but actually target the underlying disease. And by that, I think the first sign we'd hope to see is a decrease in the variant allele frequency or the burden of mutant CALR cells in the body. And then, of course, really important is that we see that this correlates with important outcomes, which includes progression to more advanced forms of MPN, so progression to fibrosis for patients who've got ET, and then of course progression maybe to leukemia, so reduction obviously in progression to leukemia for patients who do have myelofibrosis, and improved survival. So that's what we'll be hoping to see. I think we've got to wait to see the data, so I think we've got really encouraging signs from the early data that's been presented, but we're really looking forward to seeing the updates at ASH and updates as they come to see whether that's being achieved. And of course we want to see that those decreases in the mutation burden are then maintained over time, That's the other important thing. So hopefully that addresses your question, Claire.
It does, in a way more eloquent way than I could have done that myself. So I'm going to hand over to John Mathias, but I want to thank everyone who's been on the panel, but also big thanks to Charlie and also to Debs and Maz for making all these complicated arrangements work. So over to you, John.
Thanks, Claire. I was about to say exactly the same thing. Brilliant speakers, pretty much flawless execution. I'm really proud to be part of this group. I'm just going to linger for a few seconds with this QR code on the screen. If you feel like making a donation to MPN Voice so that we can continue doing events like this, you can get to our Just Giving page through the QR code. There's also a link on our website, of course. So to wrap up, thank you again to everybody involved. And I'd also like to thank all the people who've dialed in this evening, because there've been some really brilliant questions. I think they've brought out some extra information from our speakers, and that's exactly what these events are all about. So I think it's been brilliant, and the last hour and a half have flown by. Thank you very much, everyone, and very much looking forward to seeing you again at the next event. Bye for now.